The DynaWell technology was developed in Scandinavia, and what it does is allows us to simulate weight bearing in a supine position or with the patient lying down. There's no question that MRI is the best way to evaluate the anatomy of the spine. But when we do an MRI, the patient is laying down, which takes the pressure off the discs and actually widens out the central canal. So there needed to be a way to simulate weight bearing to more accurately demonstrate the degree of extension of the disc herniation pressing on a nerve, and as importantly, to show areas of spinal stenosis or narrowing of the spinal canal that could be pressing on a nerve that may not show up or may not be as impressive when you're lying down in a relaxed position. If you've ever had back pain yourself, what do they tell you to do when you have back pain? Lie down with your knees flexed. And that's what we do in an MRI. Why do they tell you that? Because there's less pressure. So that makes the MRI without the use of some type of what we call axial loading or gravity pressure pressing down on the spine. I mean, 2/3 of your weight is above your hips, and so that's what's pressing down on your spinal discs all the time. In routine MRI, we try to take away as much of that pressure as we can. What the DynaWell does is, using a safe technique, reproduces that axial load on the spine, and it does it in a way that's exactly the same as if you were standing up. And yet, we keep the patient lying down. There are such things as stand-up MRIs where people are actually scanned standing up. Problem with those, hard to stay still standing up when you've got back pain. Hard to stay still through the course of the MRI. And the resolution is probably not as good. They're lower field strength scanners. So now, at Pacific Imaging, we've put in a DynaWell system which, in appropriate cases, you don't necessarily need to do it in every case, but in the appropriate cases, we can load the spine and demonstrate things that maybe biomechanically or because of the way the spine moves and because of the way that their narrowing changes, the clinician may suspect that from his evaluation of the patient, but it can't be demonstrated on MRI unless you add that axial load. And we're proud that at Pacific Imaging we've installed that equipment to be able to do that. It's not new. It's been around for 10 years. It's been evaluated extensively in papers written both in the radiology and clinical literature, both in the United States and Europe, documenting its advantage in certain patients. With our experience in spine imaging and our expertise in spine imaging, we know which patients we're going to need to use it in, so we'll use it appropriately in patients to enhance the quality of diagnosis for the referring clinician. This is a device that it's an add-on, doesn't come with a routine MRI. Very few MRIs use them, but very few MRIs concentrate on spine disease the way we do. So what this device does is it sits at the end of the table that the patient lies on that slides into the scanner. At the end of the table is a box that has pressure gauges in it, so we know we don't crank the patient too much pressure. And then it has a harness that fits above the hips, and of the shoulders. And so we turn that, increase the pressure, and sort of pull the body together a little bit, much like when you stand up. Gravity pulls the body together. So it's doing the same thing, but doing it while the patient is lying in the scanner.
For existing practices that have MRI, is it a economically feasible device to add? Or?
It's economically feasible only if you have a large enough volume because you can't bill extra for it. It's basically something that the center is willing to add on. It's a fairly expensive piece of equipment, but we believe that it's so important in taking care of certain patients with spine disease, and really important in taking care of patients who may have biomechanical symptoms such as a chiropractor would see. But any time there's a clinician that's worried about spinal stenosis, or for a patient has what's called neurogenic claudication, where you have pain in your legs, much like if the vessels are being blocked off, but it's really because the spinal canal is being blocked off, it's very important for the clinician to know the exact detail of how narrow the canal is in order to make a decision, because the surgery is fairly extensive and you don't want to do it unless you've explored in great depth the level of narrowing of the canal that you have. And so by adding this system on to our scanner, we've made it possible to be the most accurate we can be in determining the degree of narrowing that may be causing the patient's symptoms. The articles that have been published in the literature demonstrate that it has two advantages. One is it'll see things that aren't readily observable when you're scanning the patient in a relaxed supine position. But secondly, it enhances and shows the more significance of a lesion that may be observable without the axial loading, but becomes much more obvious with the axial loading, which is the way you know the patient when they're walking around. That's really the way they are. That gives the surgeon a much higher degree of confidence in treating the patient with what they need to do, when they have the bigger degree of confidence that there really is significant narrowing there. That's the main thing that it provides. So the literature has shown that there's an increased level of pickup of the lesion, so an increased sensitivity to even find the lesion, but there's also a significant increase in the confidence level of the treating clinician based on the extra information provided from the system.
Do you do two MRIs, a loaded and unloaded MRI?
Yes. We want to see the change. It wouldn't be something you would do if you were just trying to run a mill and get as many patients through as quick as you can. It's done when you feel that your center needs to set itself up as the center of excellence in spine imaging. Then you want to provide this. And we review very, very carefully. We get extensive histories both from the doctor, but we also have the patient fill out a complete history form just for us in order that we can understand. And since we know the clinical findings in spine disease, we want to have the patient tell us in their own words what their problem is. We can then use our experience to then decide if they may have a lesion in their spine that could be seen better with the loading. But first we'll scan them unloaded, and then if there's anything at all that suggests that we should load that patient and look at it much like when the patient is really living, walking around, then we'll add that on to the scan. One of the most important things when a chiropractic physician refers a patient to us is that we find a lesion that he or she maybe should not be taken care of. And my experience in working with chiropractors over the years is that they will always refer it on to a surgeon if that's necessary. So it's both in making the diagnosis from a biomechanical point and what the chiropractor can treat and lead he or she in their treatment, but even as important in that is it's very important that we pick up the lesion and communicate it to the chiropractor that they need to move this patient on to a surgeon.